I've been actually asked to present the topic of neuroendocrinial rectal tumors, which is an anus in Hebrew. And as Professor Gross said as well, this is almost in all of the lectures, and the frequency of neuroendocrinial tumors is growing, and the rectal tumors are also becoming more and more frequent. Those that it's about 30% of all the tumors of digestive tract, of neuroendocrinial one. And the frequency, the reason that is frequency is increasing, and it's probably quite good actually, the very fact that we have more of a scans, and in cases of rectal tumors, it's probably because the introduction of the search for the various intestine tumors and an increase of the awareness of those tumors. So we also do detect additional tumors that are not adenocarcinomas, but endocrinal one. So majority of those tumors in the rectum are asymptomatic, and that they said have been discovered actually randomly during colonoscopy. And what they are, when they are detected after different complaints and bleeding from anus, pain, feeling of repeating defecation and a constant need of defecation, and they've been talking about the carcinoid syndrome. Actually, the neuroendocrinial tumors of rectum, it's quite a rare one, but it does exist as well. So when we do want to diagnose and to categorize those tumors, we say that majority of those tumors are touch causal. So when we look at this particular chart from the left, we can see that on the chart flow, we can see that the pink layer is actually the layer of the mucus of the intestines, and there is submucus, which is a whiter layer. And then we have the muscle. Majority of the tumors are in the submucous area. When we look at that, and how does it look at the colonoscopy? This is a little bit of, an enlargement, as you can see here. It's a little bit of a lump in a way. And one of the most common tests that we do in those cases is actually ultrasound performed via rectum. As you can see in majority of cases, and it said majority of those tumors are in the submucous area. There is an example here, as I showed you with this arrow, and this is this light area. This is under this white layer, some kind of a gray layer. This is basically the endocrinal tumor. When we talk about an additional assessment of those patients who have been detected with this tumor, we of course need various signs. The best parameter that we have right now is homochronin. And of course we can use also, we get them urine for 24 hours, polysaccharoxy, when people tell me that they need to fill out the whole ways with their urine. But actually majority of those rectal tumors, it's not a high percentage, but it's also part of this assessment and the follow-up of the patients. When we have various tumors, when we think might be deeper, and actually they do involve additional members and local lymphs or systemic involvement, then we need to add the CT scan as well, MRI as well, and somatostatin mapping, which is constantly a process in which we have a size of a tumor than more than 10 millimeters, so basically a centimeter. While we're looking for residual diseases, and we know that the CT as well and the MRI as well are quite limited, and this gland mapping is also quite limited in for objects of less than half a centimeter. So the threshold of detection, as we call it, is less than half centimeter. So not always if we'll do that, even if there is a disease, we will not be always able to see that. From the perspective of, so what is an approach? What is the therapeutic approach in those cases? We need to divide the therapeutic approach into the risk of such a tumor becoming local or becoming metastatic and spreading. What actually dictates here, the risk factors that dictate this risk of spreading, is the size of the tumor, of course, and this is also true for the endocrine tumors elsewhere. More than 1 centimeter size, then the risk of the local systemic dispersal is higher. Level of penetration of such tumor, whether it penetrates just the layer of the submucosis onto the mucus, or is it a bit of a deeper layer, whether it's muscle, even muscle in this way. When we have a tumor that has Ki-67 parameters, we need to know how quickly it actually splits, and then we grade it, grade 1, grade 2, grade 3. The higher the grade, the higher the risk would be of such tumor to becoming with a local involvement or systemic involvement. And when we see pathology that we receive, more active pathology, we ask pathologists to perhaps see different signs that it invaded various lymph glands during the pathological test, or it did invade it and it's actually surrounding nerves within the pathological test. Usually small tumors and their surgical risk is low. And the low risk tumors actually, so the endoscopical removal or superficial or deeper one, depends on the level of involvement of process, will be suffice. And here actually such an amputation will definitely sufficient. I didn't find a better example. This is actually something that shows an amputation using this little loop. And of course, when it's a bigger tumor, and there are various risk factors that are much more significant. When there is a metastatic disease, a local disease with a local involvement of a lymph glands, then we do need to address and refer the patient to the surgical procedure of a removal, of a partial removal of a intestine, which of course already is less obviously easy for the patient. I'm not even talking about advanced treatments, because majority of the endocrinal tumors are actually, luckily we have a really good screening and we detect them at a very early stage. So majority of those treatments for majority of those patients ended at the stage of amputation, of a local removal. And I'm inviting now to this stage to tell a little bit about this procedure of the monitoring. Our Dr. Philip Ben Natan, that we meet constantly once in half a year or a year. And since everything is good and well, I do hassle him a little bit on other endocrinal topics because I can't really get a hold of myself. So, and this is it. And I learn a lot from him on general matters in addition to medicine, because he's a doctor of history. He has a PhD in history. So I always invite him in order to learn something new about history. So thank you. So welcome to this conference, and the importance of this conference is tremendous, and I'm really very happy to be invited to participate in it. Please allow me in the very beginning to present myself briefly. And I am not a physician, as I said already. I am a historian. I'm a PhD, but in history. And I am 85 years old, and I had luck. I was lucky enough, I would say, and a pleasure, by the way, to be a patient of Dr. Osher. The topic that I would like to discuss with you would be, I do want it to be very focused, very zoomed in. I would like to present the point of a patient, the point of view of a patient, endocrinology as a medicine, as a preventive medicine, as an ultimate preventive medicine, the medicine, in order to clarify the statement, to back it up. I'm not sure from scientific perspective to what extent it's actually precise. I hope that the community of doctors that is present here will be very forgiving towards me, and I will not rip me up because of different imprecisions and accuracies. In order to clarify my statement, I would like to present you with the summary of the medical history, of my medical history from 2007. It began, well, my spouse encouraged me to go to regular testing of colonoscopy, as usually we do due to such an age after a particular age milestone. While there was a polyp detected during this regular routine coloscopy, and a biopsy clarified that there is a carcinoidal symptom there. Obviously, it has been removed during this test. After 2 months, there was a repeating colonoscopy in order to make sure that everything is clean, and it was all very clean. And this young physician, gastrologist, Dr. Ibrahim Shwedi, said that just in case, since carcinoid usually positioned in the humid parts of our body, I should go in to be tested by an endocrinologist. Obviously something that I did. An endocrinological test discovered symptoms, suspicious symptoms, additional symptoms, and from there we started an interaction, a medical interdisciplinary interaction that I was engaged in. There was an imaging, I'm not even sure how to call it was isotopic imaging. It's a nuclear imaging that discovered the beginning of a cancer of a different type, not carcinoid cancer, that positioned itself on the upper end of my right lung. Like in all of the cases, there is something that is not extraordinary. It requires a treatment, a surgical treatment, and that's what has been done. Relatively easily removed, and it has been removed. The healing was very quick, very fast. Since it was just the beginning of the process, there was no need afterwards of any treatment or therapy, and since then, since 2007 until today, yours truly is being monitored by oncologists. So up to now, we could have actually talked about a stage of endocrinology, and I allow myself to say that it was life-saving experience, since that would actually referred the attention of various authorized factors to detect something very unpleasant in addition in my body. Well, since then I've been monitored constantly since I understood the advantages of endocrinology. By my initiative, I addressed and I asked to be monitored and treated for endocrinological symptoms of hypertension and etc. in Ichilov. And this is where, as I said, I am being currently monitored by Dr. Osher. And here it turns out that what I wanted to ask again, and I wanted to emphasize again, endocrinology as medicine, a preventive medicine. You don't have to explain what is an advantage. It's obviously help us to detect an early detection of something that is abnormal. And of course, to a certain extent, as I understood out of explanations I received, this test that and today I learned that it was developed in Hadassah, Jerusalem, the chromograниum A. In this testing, there is enough to discover even hints, and not just even signs of a possible future development. Pay attention to my phrasing, future development, hints of future development, and I think it definitely expresses the whole matter of preventative medicine. And from this very moment that something like that is being detected, the whole medical attention is being paid to this particular direction, and we are being monitored. So, if so, it turns out it's not just a matter of cancer. It's not just a matter of cancer, really, but it's also a matter of really preserving a proper weight, blood pressure monitoring and management, density of bones, and I can tell you that one of my friends, a physician from, I know him since I was a teenager. When I heard about this particular test that I went through after recommendation of Dr. Osher, he claimed that it's actually suitable for him to have um, an ability to actually have a density of your brain tested. That would have been wonderful if we could have do that. But if I really could, using my medical history, as I promised, it will be just a brief description of my medical history. And I wanted just to demonstrate how it can be a life-saving and very beneficial experience, maybe not for the majority of people that are present, it's already relative, but it's irrelevant, I'm sorry, but as majority of your family, your natural milieu, it can be a life-saving experience. You should draw the attention to the significant importance of preventative medicine, endocrinology, and this is one of the most important branches that we can rely upon. And if it could have been beneficial for others in what I just said, that was my objective. And I'm willing to answer all of your questions in case you have any. Do you have any questions? I do have a question. You talked about nutrition. Did you? Did I? You did talk about nutrition. You talked about the maintenance of weight. Um, can you address that a little bit deeper? Well, considering the very fact that I'm not hearing very well, please translate what you just said. I do have some hearing deficiencies. He's asking you about nutrition, because when you pay attention that you're losing weight, then we started to monitor your weight, and he's asking you about what you were very thorough about. Thank you. And well, yeah, the whole weight issue is super important because it's a very thorough monitoring and detail-oriented monitoring, weighting. For 2 years, I lost more than 2 or 3 kilos. I try to explain that it's very possibly that what I actually can say in this medical field is a bit subjective. Obviously, someone who is lacking completely medical education, that is possible, it's probable that might be a different reason. And in order to prevent approaching the threshold of diabetes or something of that sort, I did switch to diet plan. Sugar and fat-free, and this is on one hand might contribute to this particular aspect, so I need to be closer to the microphone. Do I have to repeat what I just said? No, okay, it's fine. So that is my explanation, my initial first explanation, and the second one was that I am, well, as I did my whole life, I continued to work out. I was in competitive sports, so I know how to do that, how to actually remain fit. So this combination of a strict diet plan and workouts probably brought to this particular point. It did not persuade my physician, of course, Dr. Osher, and she still decided to refer me to the nutritionist that defined for me nutrition plan. I did what I've been told to do and then returned to things I tried to avoid without obviously endangering my health. So in the end of my breakfast, I'm eating a little bit of halva, and in the end, I'm eating some pastry, some pastry dough, and that's it.